pass on our thanks to all of your team back at the base. I know the committee would appreciate that.
Thank you.
We are going to start the first half of our time with you this morning talking about the social care sector, because we're shortly going to be doing a report into social care funding and the social care workforce. And I want to start, if I may, by playing you a couple of clips of evidence that we've received as a committee earlier on in the year from people who've been using the social care system and experienced particular problems. The first clip is from a lady called Anna Severite, who is a 34-year-old woman with a neurological condition, which means that she's totally dependent on the social care system.
For the care I receive, it keeps me fed, it keeps me clean, it keeps me watered. But I really feel I'm not able to be living a normal life. I don't have enough hours to be able to go out at the weekends and the evenings and just do a lot of the normal things that make life worth living for us. And my life kind of got split up into chunks. So how long will it take me to have a shower? How long do I need to get dressed? How long for food preparation? And that's not really about what I want my life to be. And I found myself in the position quite regularly where I have to think, well, I've only got 2 hours left this week. Do I want to do food shopping? Do I want to have another shower? Or do I want to go and meet up with a friend? And that's quite a hard place to have to live your life, where you're having to quantify the things you want to do into a small number of hours a week.
Thank you. And she's obviously can't do any of those activities without help, which is why she has to plan very carefully and make choices about those different activities. The second clip is from a lady called Deborah Gray, whose husband Atherton has early onset Alzheimer's, and she found herself facing huge unexpected care bills.
If my husband had a tumour or needed dialysis, then the NHS would pay for his care. But because he has dementia, it does not. Care homes recognise that dementia is a disease, and they charge us an extra 15% to look after him because he has dementia and because that involves additional needs. Consequently, when he went into a care home, we had to find £1,000 a week. That's £52,000 a year for his care. My husband was a doctor in the NHS, and he was really proud to be a doctor in the NHS. He spent his whole life paying his national insurance in the knowledge that when it was his turn, the NHS would take care of him, but it hasn't. Now he's unable to utter a couple of words at a time. He has seizures, he has falls, he's doubly incontinent, he doesn't recognise his own children. And it's screamingly clear that something is wrong with him, and it's a disease. So dementia is not just a matter of ageing. Liver failure isn't like that, cancer isn't like that. And it's the unfairness of the treatment of somebody with dementia that makes me really, really, really angry. It's like picking up a random card from a pack and, oh, you've got this particular one, tough. That's the disease the NHS isn't going to pay for.
So, if I could start by, as well as welcoming you, just asking your reaction to those two clips.
Yeah, well, they're very powerful videos, aren't they? And they are, in a way, effectively capture the challenge that we face as a society with finding a long-term reform for social care, because they capture two sides of the problem. One is the high bills and the high cost, and the other is the extra demands and needs that people have over and above that which for which the state provides. And the current way that the social care system operates clearly has embedded in it a series of injustices that have grown up over time. One is the system of deciding which care is paid for in the social care system and which care is paid for in the NHS, which, as you'll know from your time in my job, was essentially decided over a series of court cases rather than anybody taking a policy decision. And then the second is the fact that of course, many people, including some very vulnerable people, need care, and that care needs to be paid for. And as we heard in the first video, some people would like to have more care than can currently be paid for. So this is in a way, it highlights the size of the challenge.
Thank you. Obviously, money isn't the only solution to these issues, but it is part of the issue. And I just want to ask you about some of the figures that were given to the committee. So if you look at the next 4 years until the end of the Parliament, and you look at the demographic pressures on the social care system, the ageing population, and the increases in the national living wage that the government has committed to, the Health Foundation say that just those alone, so just additional pressures, no increase in the quality of care provided, would mean the annual budget would have to go up by 3.9 billion a year by 24/5. And then if we wanted to do something like the Dilnot reforms, Andrew Dilnot, who also gave evidence to the committee, said that's an extra 3 billion on top. And we ran those figures by James Bullion and Sarah Pickup just now, and we sort of saying, is that 6 to 8 billion the minimum necessary if you're going to sustain current pressures and start on the road of reform? And I just wondered whether you recognise those figures.
Well, I recognise the pressures. The first, as you say, the demographic pressure. So the best estimates are that the number of people who will be needing care on the best estimate of it rises from around 730,000 this year to around 820,000 by 2025, and then eventually to over 1 million. And therefore there is there's a rising pressure through demographics because people are living longer, and that's a good thing. Now, that's notwithstanding COVID, and very much with the anticipation that within the next period we get that under control and we don't have another spike with the impact that it had earlier in this year. So setting that to one side, looking through that, looking at the long term. So there is a demographic pressure. There's then a question of the pressure on the delivery of the system at the moment, which has been also challenged because of COVID, and we've put in short-term funding, but there's a challenge. And then there's the long-term funding reform question, which the videos that you showed played into it. So I absolutely acknowledge the direction of those challenges. It's a bit we're currently in the depths of a spending review discussion about exactly the level at which those manifest.
I mean, those numbers I gave you are from external bodies. You will obviously have your own department's calculations as to what those numbers are. Would you be willing to share those with the committee in order for us to produce the best possible informed report, which we're hoping to bring out in the next month?
Well, of course, I'm absolutely happy to share with the committee the work that we've done so far, but we haven't yet fully landed on a set of figures because we're at that point in the spending review.
Okay. It would be really helpful in the next couple of weeks if you could let us know where the department thinks demographic pressures will take the cost base of the system. The Dilnot figures, I think, are in the public domain anyway.
Absolutely.
But we really appreciate that. I'm going to bring in Paul Bristow and Laura Trott to ask some questions on the social care workforce. So Paul Bristow first.
Thank you, Chair. Secretary of State, I'd like to ask you a couple of questions, if I may, about the new health and care visa. It says on the government's website that the new health and care visa will make it cheaper, quicker and easier for healthcare professionals from around the world to come to the UK. Why are social care workers excluded?
Well, it's not true that all social care workers are excluded. The health and care visa extends to those who have a registered qualification, for instance, in nursing or as a doctor. So, including if you go to work in social care. However, we also have a challenge to ensure that we recruit people into social care who are already here in the UK. In fact, we've got a significant recruitment campaign underway now that you might have seen, and actually that is starting to work. So the number of vacancies, the proportion of vacancies has fallen. 2 years ago it was 8%, last year it was 7.8%, now it's 6.6%. So the vacancy rate is coming down. But the point about the social care, the health and care visa, is that it's aimed at those with that qualification which is registered.
Okay, as you quite rightly said before, parity of esteem between NHS and social care staff should be a lasting legacy of this pandemic. Don't we undermine that by having two different immigration systems?
No, I don't think so. I think parity of esteem, which is a goal that we should seek, is about employment in the sector, and about what it's like to be employed in social care, and increasing the professionalisation, as in the recognition of the skills and the capabilities that are needed to work in social care. And making sure that it's a rewarding career in the same way that we try to do the same in the NHS. Having the challenge in the immigration system is to ensure that you have a robust immigration system, yet can also deal with the challenges where we have shortages, and basing the visa on registered qualifications is a reasonable way to ensure that retains the robustness that understandably our immigration procedures require.
Okay, and just finally, countries like Denmark seem to have made it easier for professionals. We heard that through this inquiry. Make it easier for professionals to switch between health and social care.
Yeah.
Is there a case for a more integrated approach to training, in your view?
Yes.
And how do we reach a sustainable supply of new social care workers?
Yes, I definitely think there's a case for a more integrated approach to both training and employment across health and social care, and indeed the support. In the crisis, in the peak of the coronavirus, one of the things we did was ensure that there is a named clinical lead for each care home, for instance. That is bringing the NHS closer to and tying it in with the provision of care in a way that hadn't been done before. And that's just one example off the top of my head of ways that we can try to make the system of employment more integrated.
Thank you. Laura Trott.
Thank you, Chair. Secretary of State, just to follow on from Paul's question about the integrated training, I agree it completely makes sense to have greater integration and working, but in terms of career progression and development and developing that for social care workers in the same way you would for a nurse, for example, is that something that is under consideration?
Well, yes, but let me just try to pick up on the point that you make about a nurse. So within I would love to see it easier for a nurse to move between working in the NHS and working in social care. That is a particular profession that has a recognised qualification, which makes it easier to design a system around it, because there's a formal system of recognition. You are either a registered nurse or you are not, and that is all governed by the RCN. And that's why it's easier to make policy, for instance, around immigration based on registered qualifications. There's a broader point, which is trying to ensure that people who work in social care, who do highly important jobs that require crucial skills, that gets more recognition than at the moment. And I think that's another direction that I'd like to go in, because that then makes these sorts of transfers easier. Essentially, when a skilled profession like working in social care has the recognition of formal qualification around it, for instance, or of professional recognition, there's a number of different ways you can do that. That makes it easier for this sort of transition.
And when are you thinking about bringing forward proposals along those lines?
Well, we're working alongside as part of the social care reform, where we got to quite an advanced stage of work on this ahead of the pandemic. Everybody, in the debate around social care reform, it's entirely natural. I understand why it's this way. That the first thing people think about is the funding reform, and of course that's critical. But there's so many other parts to social care reform than the funding reform. There's support for the workforce, including these sorts of flexibilities and integration. It's a common part of employment practice that those with recognition of capabilities and qualifications find it easier to have flexibility and transfer between different parts of a profession. For instance, around the use of technology, for instance, around the use of intergenerational care. There's a whole series of areas where we can improve the way that social care is delivered over and above funding reform.
Thank you. We're going to come back to you later, Laura, but Barbara Keeley next.
Thank you, Chair. Well, the last 10 years are littered with promises on social care, with plans for white and green papers, an actual commission, legislation brought in and then postponed. In terms of the answers you've just given, when can we expect a long-term funding settlement for social care to be announced, together with the government's plans for reform? Because it would be easy to get lost in the complications which you've just outlined. But I think, local authorities and care providers need to know when there are going to be plans announced and when we're going to see those plans for reform.
Well, it's even worse than that, Barbara, isn't it? Because it's over the last 20 to 25 years that people have come forward with proposals and commissions and then not implemented them. And in fact, the legislation that you mentioned...
Your government's responsible for the last 10, if I could just point that out. You're responsible for the last 10. So let's look at that. Why haven't we had the promises realised from the last 10 years?
Yeah, I think it's actually better for the nation to try to depoliticise rather than politicise this. And that was the point I was making. This is a long-term challenge that the country has faced. So the answer is we've made clear manifesto commitments. And obviously, and we were doing a huge amount of work on this immediately after the election. Obviously, the coronavirus crisis has delayed that work, and I think people will understand that. I mean, not that we haven't been working on social care, we've put a huge amount of money in, and actually we can come on potentially to some of the reforms that we undertook in the heat of the crisis that have made some really positive differences. But that is another challenge, but the internal discussions on these reforms have since then picked up again.
So no answer on when. One of the most negative aspects of underfunding of social care is the way it leads to autistic people and people with learning disabilities being left or transferred to secure hospital wards. Very often when local authorities can't afford to pay for the care they need for those people to live independently. You know, Secretary of State, well, the case of Bethany, and you know it took 14 months to get her moved out of an ATU into community care, where she is now happy, I understand. But this is a key issue, and it's a win-win situation, because good community care can be cheaper than the millions spent by the NHS in those inappropriate institutions, and we've got 2,000 people stuck in them. But local authorities have to be able to fund it. Now, I know that you've announced £20 million a year for this, but that level of funding is nowhere near what is needed. My party announced £355 million a year for that policy. So what are your plans to ensure that more than 2,000 people like Bethany can get the support they need to live independently in the community?
Well, I'm very glad that we managed to make significant progress in the individual case that you raised, but it shouldn't have to take my personal intervention to solve that sort of problem. I'm very glad to say that the number of people in secure inpatient units has fallen further since then. I was looking through, I don't have the exact figures in front of me, but it has fallen further, and you point out exactly why this is a good thing, because often the patient outcomes are better and it's cheaper for the system as a whole. The money we've put in has been very effective, and just to be clear about what this money is for, there is an overall saving to the system of people being in the right care, especially if that right care is community care rather than a secure inpatient setting. The challenge was that there's a double running cost in the transition as you support somebody to come out of an inpatient setting, often because of the sensitive nature of the vulnerable individual concerned. You need to both have the community team there ready and already employed and set up at the same time as keeping them supported in their inpatient setting. And so the money has unlocked the ability to get the community team there earlier to allow to support a successful transition into the community for some very, very vulnerable people with very high needs. So I'm really pleased at the progress that we've been able to make on that. And I pay tribute to those who campaigned on this front, because I totally agree with the importance of this direction of travel.
Thank you.
But there are 2,000 people. I think we really need to be looking at that as a more urgent issue.
Well, as I say, that number has come down significantly. There are some who have, for judicial reasons, there are challenges, and so it's important to go into each case. We've gone through to review the cases, the most serious cases, to assess in each case whether there's the ability to move them to a community setting, and as I say, we've managed to bring the numbers right down.
Thank you, Barbara. It's time to move on to more general topics. I just want to ask one brief question to kick off about this morning's news on the pandemic and the recent rise in infection rates, which is obviously very concerning. Indeed, we are now, I think, higher than the levels above which we would ordinarily have decided to quarantine people who are coming from countries that have the levels that we now have of new infections. I just want to ask your judgment, assuming we're following a similar trajectory to countries like France, Germany and Switzerland, do you see us going into a spike, or could this be a need to hunker down for a proper second wave?
Well, the number of cases has risen in the past few days, and this has happened right across the UK, and I'm obviously concerned about that. There is no inevitability to a second There is no inevitability to a second peak. It depends on the actions that all of us take. Of course, in government, we're concerned about this and we keep all options open. But everybody's got a part to play. And the strategy that we've discussed many times and that we've outlined is really clear, which is that the first line of defence is social distancing. The hands, face, space campaign, communications campaign, say wash your hands, cover your face, keep that distance, is very important. The next line of defence is testing and tracing, and that is radically stronger than it was in March when we faced the first wave. And we now, per head of population, have one of the biggest testing systems in the world, and our contact tracing is very, very sophisticated. And then the third line of defence is local action. And you've seen that I've taken quite robust local action in areas where there's particular spikes. And I don't like doing that, but I don't resile from doing it because it's necessary. And if you look at Luton or Leicester, then you can see that it's effective. But it is so important, as Professor Jonathan Van Tam said yesterday, that people take their responsibilities seriously and people don't become relaxed about this virus.
Thank you. Luke Evans.
Thank you, Secretary of State. And I'd like to talk about patient recovery from COVID.
Yeah.
One of the great news stories that was hidden over August was that if you are admitted to ITU now, you're 50% more likely to survive than where we were before because
Yes.
the advances dexamethasone.
Yes.
That creates a little bit of a challenge though, because more people go to ITU or come out of ITU who need rehab. And I'd like to ask, what strategy has the NHS got in place to help rehab patients who are coming out of ITU suffering from COVID?
Look, first of all, the first thing to say is that people coming out of ITU alive who would otherwise have died is the sort of problem we like to have in the NHS. This is a good problem. But there's also absolutely no doubt of the severity of the consequences of long COVID. But I just want to slightly reframe the way you describe it, because the long-term impacts of COVID are not very strongly correlated with the severity of the initial illness. And so whilst we have a very significant amount of work going into supporting those who come out of hospital, having been hospitalised with COVID, and we've put in July, we put in £8.4 million into a research effort, and the NHS has set up a long COVID service. This is not just about people who are hospitalised. In fact, and this is really relevant for now, because the latest rise in the last few days has been largely amongst younger people, but it doesn't matter how serious your infection was first time, initially, the impact of long COVID can be really debilitating for a long period of time, no matter if your initial illness was wasn't all that severe.
Well, I'm really glad that you picked up on that, and it's good news to hear because the Royal College of GPs have come out saying that we should have post-COVID clinics across the UK. Can you update us then on how the progress is going to get that sorted? Because I think you're exactly right. Patients have differing streams of how they present
Yes.
and what they're left with.
Yes.
And that's one of the big concerns that they have. So could you expand on what you just
Yes,
mentioned?
so the NHS set up long COVID clinics and announced them in July. I'm concerned by reports this morning from the Royal College of GPs that not all GPs know how to ensure people can get into those services, and that's something that I'll take up with the NHS, and I'm sure that we'll be able to resolve.
And in terms of that, I mean, research is still coming out. You mentioned research going in. What about education for professionals, for the public, of what to look out for, what this looks like? Because clearly, people may not even be aware that they've had COVID and then having symptoms that are leaving them feeling tired, loss of sense of smell, muscular weakness. Is there an education campaign that you could carry out to professionals and the public to make them aware of this?
Well, we have been circulating the evidence to GPs in the way that the NHS does, and with a new disease like this, obviously that's particularly important as new evidence comes through. That's partly what the research effort is all about, but we also need to highlight to the general public that there is support available in the NHS COVID service. One of the challenges is that there are not easy and clinically validated treatments for long COVID. The treatments that that our research program has discovered, like dexamethasone being the primary around the world, that was discovered in the UK, and but that's for hospitalised patients. And so there is a challenge, which is supporting people when actually there isn't a readily available treatment.
And the final question from me is, with regards to all this, there is a concern that you can get reinfected with COVID.
Yes.
Have you got any update for the public of whether that is still applicable and whether or not there is immunity out there?
Well, it's clear that there is some immunity from having had COVID, because we can, for most people, because we can see the rise in antibodies that follows from an infection. But we have also just started to see the first credible cases of reinfection. And through genomic analysis, you can see that it's a different disease to the one that the person got the first time round. But in all the cases that I have seen, it has been an asymptomatic second infection that's been picked up through asymptomatic testing. But the hard question is how, because one of the most difficult parts of the dealing with this virus is asymptomatic transmission. What we don't yet know is the transmissibility of the disease, even from an asymptomatic person who might have had the disease before. But we've got a huge amount of work going on into answering that question. The answer to that question obviously ties into the effectiveness also of the vaccine. We have a much higher degree of confidence that the vaccine gives immunity, and that obviously is one of the things that we're testing as part of the vaccine trials, which, as you know better than anybody, you can never have confidence in them coming to a successful conclusion until they do, but they are making good progress.
Thank you. Just before I bring in Neil Hanvey, I sent you a couple of weeks ago a letter from a lady called Robin Gorner, who speaks for an association, a group of people who've got long COVID, as she does. I just wondered if it'd be possible to have a reply to that letter fairly soon, because they make some very sensible suggestions.
Yes, I saw the letter last night, and we'll get a reply very quickly. This is an incredibly important area to me.
Thank you.
And the other thing I'd say on it is this, that people of all ages are affected by long COVID, and people who are younger, who might think that they're unlikely to get severe symptoms or die of COVID, can still have a terrible illness that completely changes their lives for months and months and months. And we saw this morning the evidence from King's College that shows around 60,000 people who they have found who have conditions of COVID that last over 3 months. This is a really serious consequence of the disease.
Thank you. Neil Hanvey.
Thank you very much, Chair. Thank you, Secretary of State. Any member of a clinical team would say that trust and confidence in the team is one of the most important aspects to the care that you provide to a patient. And so with this, public trust and confidence with COVID is absolutely essential. We've been reassured on multiple occasions that the decisions are led by the science. And I just wanted to explore that a little bit with you. And I'm turning the clock back to June, and Professor Sir John Edmonds said, and I'll quote him verbatim, "I wish we had gone into lockdown earlier. I think that has cost a lot of lives, unfortunately." On the same weekend, you said that you felt that the government had taken the right decision. And I'd just be interested to know if you can detail what scientific evidence you referred to when you said that you were guided by the balance of opinion. What were the convincing premises that were presented to you, and what enabled you to feel robust enough in your position to challenge an esteemed professor?
Well, the advice as ministers that we on which we base decisions, guided by the science, is obviously gathered broadly, and there's a role for a number of committees and a breadth of scientists, and then is presented to ministers by the Chief Scientific Advisor and the Chief Medical Officer. And the Chief Medical Officer, obviously, in each nation of the UK. And the decisions that we took in March were guided by the science, in the same way that the governments of the devolved governments in Edinburgh and Cardiff and Belfast took decisions at the same time. So that was guided by the science in the same way.
So that's quite an extraordinary decision. It's not something that cabinet secretaries or politicians take often, to lock down the country. So I'm just curious as to whether you can remember what was convincing about the decision. What were the elements of scientific evidence that were presented to you that made you believe that that was the right time to make the decision? Can you recall what was the clincher?
Well, the clincher was that the number of cases was going up, and it was clear we needed to take significant and urgent action, which we did.
Okay. And with regards to the comments that were made by Sir John Edmonds later, Professor Sir John Edmonds later in the year, that there was a discussion about locking down earlier, and that he regretted that that decision wasn't taken a week earlier, and he projected, as an epidemiologist would do, what the consequences of that delay would be. What was your recollection that gave you the confidence to say that the government took the right decision at the right time?
Well, there'll be there's plenty of scientific debate around this question,
what convinced you?
To take the action necessary, it was absolutely clear that the number of cases was rising, and we'd seen the rise in the number of cases happening elsewhere, and that it was clear that this was a very significant disease. So
I appreciate that.
In
the heat of the moment, sorry, Secretary, I appreciate in the heat of the moment that you felt that was right, but I'm talking about your reflections on the 7th of June, where you said that you discounted the opinion of Professor Sir John Edmonds, and you felt that the government had taken the right decisions at the right time. What gave you the confidence to make that comment some months later?
Well, the thing is that you take decisions based on the information that you have at the time, and this is, all four of the UK governments took those decisions. Sure. At the same time. I remember being in those meetings when they were decided on.
Okay, so just final point, if I may, Chair. So I understand that in the heat of the moment you make decisions, but although Sir John was able to reflect that perhaps we should have gone earlier, you didn't feel that that was the case.
Well, as I say, there's a historical debate that will historical debate about this point, and understandably, I'm focused on ensuring that we stop this sharp rise that we're seeing right now, and different scientists will make their points. And the good thing about science is that you have a debate and you listen to all of it, and then formally I'm advised by the CSA and the CMA.
Thank you, Chair.
Thank you. So next, I'd like to ask you, Secretary of State, about a report that we are shortly going to be publishing about the impact of the pandemic on core NHS services, the stuff we do in peacetime, as it were. And I want to start, if I may, by playing you a clip from a lady who gave evidence to the committee called Deloney Carlisle. She's 55, and she has an incurable but treatable cancer. Mm-hmm. This is what she told our inquiry during the summer.
As I started the lockdown in a clinical trial, I had a CT scan. The clinical trial showed that all my cancers were growing, and my doctors told me that I needed some chemotherapy. I then fell into a hole where I was absolutely in limbo. I didn't know, I'd had no communication about when this chemotherapy might start. So for most of the lockdown, I've been sitting here at home, knowing that all the cancers are growing, knowing that the tumours in my lung, in my liver, in my spine are all busily growing, and absolutely no word at all from the hospital about when some treatment might start. Now, I'm a single mum with teenagers at home. I absolutely, my priority is to stay alive. And I can't tell you how difficult that limbo period has been.
What's your reaction to that?
Well, my reaction is to try to solve the problem in this case, and I very much hope that that since then that communication from the trust has happened, and my heart goes out to Deloney, and clearly we need to make sure that people get the cancer treatment that they need. There were, of course, important clinical reasons why sometimes treatments had to be paused, but that had to be done on an individual clinical judgment and communication with each individual patient. and I very much hope that that problem has been fixed already, and if it hasn't, I'd be very happy to intervene to ensure that it is.
Thank you. I think in that case it has actually been fixed, but it was probably illustrative of some general issues. On the 17th of March, just before the big lockdown started, Sir Simon Stevens sent out an instruction to the NHS saying that cancer treatment and other clinically urgent care should continue unaffected. In your view, has the NHS delivered on that promise?
Well, there are some cancer treatments that, according to clinical advice, were not appropriate to do when there was a pandemic. Now, here I defer absolutely to clinicians who should make these decisions. But where it was possible to continue cancer treatment, of course it should have continued. But in some cases that wasn't clinically appropriate. For instance, where a treatment was going to reduce the immunity of a patient, which might leave them more at risk because of the treatment, because there was a pandemic about and people might have caught coronavirus. So I appreciate that some treatments had to be delayed for clinical reasons, but that had to be done on the basis of an individual clinical decision about each individual patient.
So you're confident that where there was a clinical reason that it would be unsafe for someone to continue their cancer care, then it might have been interrupted, but otherwise it should have continued.
I'm confident that was the policy, but the policy was also that you should communicate with each individual patient, and that clearly didn't happen in each case.
So people like Professor Carol Sikora say that delays in cancer care could have potentially caused or will cause the death of 30,000 cancer patients. And the IPPR said recently that 5-year survival rates will now fall for lung, breast and colorectal cancer. Do you have any estimate of the number of excess cancer deaths that may end up being caused by the pandemic?
We don't yet, because it depends on the speed at which we can get through the backlog. So the backlog, as measured by the number of 62 plus days waits, has now more or less halved. And I'm pleased we've been able to make progress against the backlog. But clearly, so long as that exists, there's a problem that we need to address. Because we need to not only get back to where we were before COVID, but we need to keep having earlier and earlier intervention. And in fact, I'd say one of the big lessons of COVID for the nation and the way we have run our health service is that there wasn't nearly enough focus on diagnostics before and far too much on patching things up afterwards. And this is true, obviously, in terms of testing, the testing regime, testing capabilities that were available for coronavirus. It's also true for other infectious diseases, like the British approach to turning up at work if you're soldiering on, if you've got a runny nose, is an outlier internationally, and people should actually protect and look after their colleagues rather than do that. And the same concept is true in terms of diagnostics of cancer, where there was already a program of work underway to try to expand diagnostics, because we need to be identifying earlier, and that was started before my time when you were Health Secretary, and is something that we need to accelerate further.
So do you accept that one of the reasons why some of these cancer treatments have been delayed has been that cancer patients themselves have been nervous to go in for their treatment because they're immunosuppressed and they're worried they could be particularly vulnerable if they catch the disease? And I just wondered, as part of Project Moonshot, which you've announced, which I think sounds very exciting, but might it be possible to introduce weekly testing, twice weekly testing of staff in cancer units, just to completely put people's minds at rest that they're not going to catch the virus if they go in for their cancer care?
Well, there's lots of things in that question. Firstly, in response to the first part of the question, absolutely we need people to come forward if they've got a concern, and in fact we put a quite significant marketing budget behind trying to get that message out under an NHS-led programme called Help Us to Help You. And the concept is help us to help to treat you, and if you have a lump you must come forward. And we made, as soon as we got through the initial peak, we got started working to get that message out. The next point about further reassurance through the use of testing is absolutely an option once we get to the stage of having the rapid turnaround next generation tests in huge quantity. And we've been working on that project for some months and been able to talk about it in the last couple of weeks. And Operation Moonshot and the concept of mass testing is both about finding the virus and therefore being able to suppress it, but it's also, exactly as you say, about giving people the confidence to do other things that are important, whether that's social or economic or indeed looking after their health.
Just a final thing on that. There are obviously some big problems in testing capacity right at the moment, notwithstanding those big ambitions. And Sarah J. Marsh, who heads the testing programme, put out a tweet this morning apologising to people who can't get a COVID test. And she says that it's not the testing sites that's the pinch point, it's the laboratory processing. How soon do you think it will be before those issues can be resolved?
In the coming weeks, we're working on it incredibly hard. Sarah J. Marsh is leading that. She's an absolutely exemplary leader and we're doing everything that we can. We have had these operational issues that I've talked about. We've had a problem with a couple of contracts, and we discussed some of that in the House of Commons. But it's a matter of a couple of weeks until we can get all of that sorted. In the short term, in the immediate term, we've already put in certain solutions to ensure people don't have to travel more than 75 miles. I appreciate 75 miles is far longer than you'd want to go, and indeed the vast majority of tests are much closer than that. We've also successfully continued the rollout of asymptomatic testing to care homes, even despite these pressures, because of the importance of that.
Thank you. James Davis.
Thank you, Secretary of State. I was pleased to hear you refer earlier to long COVID syndrome and what you're doing to tackle that. There was a paper in the BMJ recently suggesting that up to 10% of those infected, possibly 60,000 in this country, have the condition. And you referred to the long COVID clinics that are being set up. Could you give some idea of the number of those across the country, the level of access to them, and how we're going to make sure that professionals, particularly in primary care, are aware of their existence?
Well, this is a project in England, and I've had discussions with my colleagues in devolved nations about it, but this is an area of responsibility that's devolved. The short answer is they're rolling out, and we need to get them rolled out as fast as possible. At the same time, as I said to Dr. Evans, we've been communicating with GPs, other primary care professionals, to be able to, with the latest insight into how to support people. But unfortunately, there isn't a treatment.
No. There's a good opportunity to highlight the fact that many in the ME, chronic fatigue syndrome community, feel that access to services isn't always what it should be, and I wonder whether this might form a template for improved facilities for them too.
Well, I'll take that point away. It seems very sensible.
Okay, thank you. The Chair was discussing with you provision of urgent care cancer services in particular. I have a question about routine and elective provision, because clearly the longer that is delayed, the more people suffer, but also the system begins to break down in terms of attendances at A&E unnecessarily and so forth. So what is your assessment as to the provision of those services currently, outpatient appointments and elective surgery?
So if we take the two in turn, in terms of elective surgery, in England, the standard of treatment for elective surgery is, the goal is to reach 95% of normal over the autumn. And in many areas we've basically nearly got back to normal, but of course that's really hard because of the need for infection control. And in those areas where there's aerosol generating procedures, obviously it's yet harder. And using testing to give people confidence that they are safe. And the recent updates to infection control advice that went out at the start of this month will help to get those elective rates back. And then when it comes to outpatients, there's a good side and a bad side. The good side is there's been a radical switch of outpatient appointments to telemedicine, which has been a very good thing, and actually increased access in many ways. But there's also, obviously, it's been harder to deliver face-to-face appointments, but that is coming back now as well. So on outpatients, because you can use telemedicine which is much better for the patient and much better for the clinician, where it's clinically appropriate, actually that's been able to take a lot of the strain. The surgery is much more challenging because obviously you can't replace surgery with telemedicine.
Yeah, indeed. And the final question from me relates to the uptick in infections more recently. Many people concerned, are we heading towards a full lockdown again? What does it mean for Christmas? What would you say to people who are worried about the direction of travel?
Well, I'd say that it is for all of us to take this very seriously indeed. And we've seen in other countries that if you don't take a second spike seriously, then it can lead to very serious problems down the track. Now, I want us, if at all possible, to get to a position where we can all have the sort of Christmas that people yearn for. But that will require everybody to play their part, to follow the social distancing, to follow basic hygiene. The hands, face, space concept has been developed as an easy way to remember the 3 single most important things that individual people can do.
Thank you.
Thank you very much. Now we've got Sarah Owen, who wants to ask about some women's health issues.
Yes.
Thank you, Chair. I've got a question about women's health, a very specific one, and then moving on to the predominantly women health workforce. 1 in 4 pregnancies end in miscarriage. I know this from personal experience, having had 2 miscarriages before my rainbow baby. Women have shared their added stress and anxiety of going into hospital for scans and routine appointments during the pandemic without any personal support whatsoever. I genuinely can't imagine what it would have been like without my partner beside me. So could you please explain to these women why it's safe for women to go to pubs with their partners but not have their partners by their side at what is one of the most anxious times for parents?
Well, I absolutely agree with you, Sarah. We've made we've removed national restrictions on people having birth partners with them whilst they're giving birth, and the advice from the Royal College of Obs and Gynae supports birth partners being there, and this is down to the decision in individual circumstances is down to
Secretary
individual.
of State, sorry, that's fine for those that get to the stage of actually being able to give birth, but it's during all of the maternity services running up to that point that I think is in question.
Yeah, okay.
And if it's a question of whether PPE is in still such short supply that this vital support can't be offered, when do you think that will be rectified?
No, there's no problem of a supply of PPE, and we're now, in fact, on PPE. We're now rebuilding the stockpile, so that is a problem that has been fixed. The advice on the ability of people to go with their partners or with their partners to a maternity visit is an incredibly important point. As I say, the questions have been devolved to individual institutions, taking into account the local director of public health's advice on the risk in that area. But I've heard loud and clear the call for better access to maternity services, both during pregnancy and at a birth. And I've also had discussions with the all-party group for maternity and maternal health, and this is something that I've taken up with the NHS, and I hope we'll be able to make further progress on soon.
Thank you. You talked a little earlier about the British sense of soldiering on if you have a runny nose, putting possibly colleagues at risk. Do you accept that by paying just statutory sick pay levels to care workers, that you're forcing them to do just that, even if they're sick or have symptoms, putting themselves, colleagues and patients at risk? I mean, if you couldn't live on £94 a week, why are you expecting care workers to do so, particularly during the pandemic?
Well, we're not expecting anybody to live on that level of income alone, and when it is in the and for long periods of time, there is the important support that most employers give, and we've made changes to do that in the health and care system, not least with the Infection Control Fund in social care, £600 million of taxpayers' money. So this is a really important area. It's a really important area of culture change.
Okay, so you've said that it's a very important area. You gave exactly the same answer to kind of miscarriage support and maternal support. Is there going to be any action on these important areas?
Well, yes.
Okay. I'm going to move on to another question. And it's around bereavement. Too many people have lost their lives prematurely during this pandemic, and too many loved ones have had to grieve alone. This is having a huge impact on people's mental health. Are there plans for the government to look into the options of bereavement bubbles?
I'm so sorry, I missed the end of the question.
Are there plans for the government to look into the options of bereavement bubbles?
The answer is that the rules around social contact for people who are bereaved need to take into account individual circumstance. And I've been clear about how we, for instance, changed the rules around funerals to allow a more liberal approach to people going to funerals because it's such a critical moment. The rules are clear that where there are exceptional circumstances, then people may be able to act differently. This is true, for instance, around childcare as well. Having a set of having people behave in a reasonable and sensible manner around being able to support each other through bereavement, for instance, is incredibly important. Now, none of these things are really straightforward because the nature of social distancing rules are that there are an awful lot of exceptional circumstances that you have to take into account. What really matters when it comes to social distancing is that people follow social distancing where that is necessary, especially around social events, in order for us to be able to act as a society with compassion when people need that extra support in exactly the sort of way you described.
Secretary of State, thank you for that answer. We've heard consistently evidence to this committee that during the pandemic, countries that have perhaps fared better than us have had very consistent, very clear communication, and that communication has been an issue throughout this crisis. And I think it's very difficult to communicate why it is that somebody might be able to go to the pub with a group of people but not be able to be there with a loved one when they are grieving or perhaps going through a very stressful period of their life, such as going to routine maternity services. I really, really must stress that there's the ambiguity that you've just given in your answer, I think, demonstrates the problem. And I've got my last question because I know there are others due to come in. Over 900 healthcare workers have died during this pandemic. Do you plan to meet with the families of NHS and social care workers who have lost their lives during this pandemic?
Yes, of course. I'm very happy to meet with and have done, and have written to some of the families as well.
Thank you. Next we have Taiwo.
Thank you, Chair.
Secretary of State, you mentioned earlier that test sites shouldn't be more than 75 miles, but a constituent of mine and his children were directed to a site which was 215 miles away in Moffat, only just yesterday, nowhere near Coventry. No parent should have to be put in that position. And this clearly shows a lack of regard and poor handling of coronavirus in towns and cities outside of London. Is this truly acceptable?
Well, it is a challenge. It's an operational challenge. I'd love to have the details of that example because we've put in place a policy of people getting tests within 75 miles. So that's the first I've heard of that happening since we put that policy in place. But clearly, we have this enormous testing capability, and the vast majority of people get their tests locally and get the results back quickly. But as I say, and as we discussed earlier, there have been these challenges, not least with an increase in demand for testing.
It's fine. I wrote to you yesterday, and I hope to get a swift reply from you. My
Great.
next question
I'll look straight into it and get back as soon as I can.
Thank you. My next question is about social care in England. Over the past 10 years, we can say that social care has been nothing short of woeful. Whether it's been the botched reforms or the lack of funding for local authorities like mine in Coventry, we've had to bear the brunt of the government's failures. This has meant that older people and those with underlying health conditions are at an even greater risk from the coronavirus than the rest of the population. So, Secretary of State, my question is, after such a lengthy delay in bringing forward plans to address the level of care for vulnerable elderly people in England, what is the government doing to address the long-term deficiencies?
Well, firstly, I don't characterise your. I don't agree with your characterisation of social care, where millions of people work incredibly hard to deliver the very, very best of care to people who are often vulnerable and including towards the end of their life, but actually of working age as well. And I think we should support our social care workers and describe the amazing system of love and compassion that they deliver. Over the last 5 years, national funding for social care has increased by 2.4 billion. That was before the pandemic. We then put in the last year an extra 1.5 billion of funding uplift. And then during the pandemic, we brought in the infection control fund that we discussed earlier, and also gave extra funding to local authorities, in part to support social care. In fact, one of the changes that we brought in that has been very successful has been the discharge fund, £588 million, that runs until the end of this financial year, which allows the NHS to pay the first 6 weeks of social care funding. And I don't think anybody should underestimate the importance of this particular change. It means that when people are leaving hospital, the funding is sorted for 6 weeks, which means that a clinical decision on the appropriate care can be put into place, so whether they should go into a care home, nursing home, or into the community. And then once they're in the right place, the long-term funding package is put in place. It helps hospitals because it means that people can get out of hospital when it is clinically right, rather than waiting for a package to be put together. But it crucially also means that people can go into the right type of social care, whereas previously there was strong evidence that more people were going into into care homes than was clinically advised, and this change of policy that we put in place in the peak of the pandemic has had a very positive impact both on hospitals and people going into the right sort of care. So, I mean, that's a long answer to the question, but we've put in extra money. We've made changes that have improved where people end up in social care that we shouldn't underestimate. And I think it's incumbent on all of us to support the staff who live in, the staff who work in social care, who've done such an incredible job.
Thank you, Taiwo. Have you got any more, or are you done?
Yeah, I just wanted to follow up on that. I do agree that the social care workers are very hardworking and very passionate. But what I was referring to was the past decade of cuts to local government, which has been about 7.7 billion. Now, my question is, how can we expect long-term funding settlements for social care to be announced together with the government's plan for reform? And is your department estimate the level of additional funding that social care needs? And how does the department aim to reach this estimate?
Yeah. So, well, it's absolutely fair to ask that last point in the question. However, it's really important to do so on the basis of the increase that we've seen over the last 5 years, especially in the last year, the $1.5 billion extra spending power, $1 billion from central taxpayers' money and $500 million from an uplift in the social care precept. And then there are these demographic pressures which are going to increase the costs. And as I discussed with the chair at the start, I'm not able yet to give you a figure for those, and that's part of the spending review discussions.
Right. Well, we would be helpful for any guidance you can give us, because we're going to be finalising our report in the next couple of weeks.
Okay.
So
So obviously, if we don't get any information from you, we'll have to use the external numbers.
Of course. Well, and a lot of the analysis is in the public domain about the various different cost pressures.
Thank you. Now, Barbara had a quick follow-up question, I think, on the pandemic, and then we're just going to finish with 2 brief non-pandemic areas.
Okay.
Yes, I should say I'm in the local lockdown area of Greater Manchester this morning. Like people across other areas of local lockdown, I'm sure, my constituents are growing weary of not seeing their loved ones at home, or not seeing friends and family members. To be able to safely lift local lockdown restrictions while we have the higher case numbers that we're seeing now, our local leaders in Greater Manchester have asked for 2 things: extra resources for testing and contact tracing, most importantly with teams being led by local directors of public health who are doing a much better job at getting through to the contacts, and proper financial support for people asked to self-isolate. Will the Health Secretary agree to that? And if he does agree to it, how soon will it happen?
Yes. Well, I'm very glad to say that all of that is already happening, and we've put in place support for people to self-isolate in parts of Greater Manchester and East Lancs, and we're watching very closely how effective that is on increasing the numbers of people in the contact tracing system. And we work very closely with one seamless contact tracing system across national and local areas. And the way it works is that the national system essentially goes first and contacts people and manages to get hold of a large proportion of those contacts, and then the contacts where we haven't been able to get there through the mass national system, those contacts are passed to the local authority, who then obviously, exactly as you say, with the Director of Public Health, have got boots on the ground, will have that local knowledge and local intelligence. And it's the...
If I could say, I understand how that works, today. I've talked about it endlessly with our Director of Public Health, but it's not happening in the way you described. What our Greater Manchester local leaders are asking for, and they're asking for it in other parts of the country, is for the Directors of Public Health to lead the effort, not for them to wait to be past contacts, but to have the resources in our local area. And you've seen the spikes that we've had with 7 out of 10 of our Greater Manchester boroughs now in the red. We need those extra resources locally because our local teams are much more successful.
Well, as I say, there is one system, and it's a system that works with both the national system, where very large resources can be brought to bear on one individual area, and then locally. And then, of course, there's the complex, there's the institutional settings where we need to do contact tracing as well. For instance, the care homes that might have a case where you need to go into the institution as opposed to the contact with the individual person. So that is, I think we're violently agreeing that the local element of that is incredibly important. But it's the combination of the two where you can get both the scale and the local boots on the ground that is going to make this, that is what makes this work effectively.
Thank you.
So will you transfer
last quick one, Barbara.
Just a final point. Will you transfer resources so that we can have more local boots on the ground? Because with the peaks we're seeing, that's what we need.
We have done that, and we absolutely have a policy to do that where we see the spikes.
Thank you. Just going to wrap up with two other areas not directly related to the pandemic. Dean Russell is going to ask on mental health.
Yep.
And then Laura Trott on maternity safety. So over to you, Dean.
Thank you, Chair, and thank you, Secretary of State. The two questions I've got are related to mental health, but also for one specific group, for the deaf community, who have been very anxious throughout the pandemic and moving forward. One of the biggest challenges, as you know, is there's 150,000 British Sign Language users across the UK, and the cost of the basic service, as I understand, to provide a BSL for those who are engaging by the telephone via an app is around £10. So it's cost about 1.5 million over the course of the year. As I understand it, I was reached out to by a charity called Sign Health, and they're saying that service at the moment isn't being covered by the NHS. They're able to try and cover it as part of their charitable donations, and they're getting close to running out of money. So is it possible to confirm whether the ability to enable sign language to be available to all who need it is possible moving forward, and that the NHS could fund that, please?
Well, I'm very happy to look at that. It seems very reasonable. Let me see what I can do.
Thank you. And the second questions really are around mental health, but in particular children's mental health. I'm conscious that for many years there's been a challenge around support and ability for children to get mental health support through the NHS and wider. I know there's been an awful lot of work done on that, and Claire Murdoch has given excellent evidence to this committee. But looking forward, we're going to have mental health challenges for children who've been in lockdown and their families. What provisions are being put into place for the rise in mental health need, and also to ensure that provision is as robust and as strong as possible in the coming months and years?
Absolutely. It's an incredibly important area where, within the increase in funding that the NHS is getting over the next 3 or 4 years, we are the fastest increase within the services in the NHS is in mental health. And within that, children's mental health is getting the fastest increase. So it's not just about the money, but the money, of course, is very important. And at the same time, we need to develop and improve access to services, including where appropriate and where it's best used using digital technology. But that isn't that will help, but it isn't the solution to all of these problems.
And may I also ask, just with regard to mental health provision, obviously at the moment people, if they need physical health support with medicines and so on, they would walk into their local pharmacist. I wondered if it's possible to look at whether pharmacists could also be a front line for mental health with regard to mental health first aid training, with regard to support, to be a sort of a signpost to additional services. Is that something that we could potentially look at, or has been looked at over recent months as times have changed?
Yeah, it's not something that I've looked at specifically. If we can make that work, I'd be open to it. We've put in the focus, especially for paediatric mental health, has been to put support into schools to make sure that they have firstly they have a mental health coordinator who can then make sure that the connections are made between the school and the local children and young persons mental health services. And so we've done it through schools, but I'm always open to ideas, and this ties together two things that are very important to me. One is the importance of having high quality mental health services that are easy to access. The second is the importance of putting more services through pharmacies who are there in the community, rooted in the community, and readily available. So I want to support pharmacies and I want to support mental health. You brought the two ideas together, but it's the first time anybody's put that idea forward, so I'd want to then go and reflect on it.
Thank you. And just very finally, to any parent who's out there, their children are just going back to school, anxiety may be high. If their child, they feel that their child needs some mental health support, what advice would you give them right now, please?
Well, in the first instance, they should contact their GP or they should contact one of the widely available and excellent charities that provide mental health services, and in particular, for instance, Mind, the ability to get support. The single most important message from all of us is that there is help, and people should ask for it. And that often is the first and most important step in treatment for mental ill health.
Thank you very much indeed, Dean. And then finally, Laura Trott on maternity safety. Laura.
Thank you, Chair. Secretary of State, can you tell me, has there been a rise in either maternal mortality or infant mortality during the pandemic?
There has the Office for National Statistics published the data on this, and in fact they've published more data this morning. This is on mortality across the board. In the case of cases notified to the UK obstetric surveillance system, for those who have had, those women who've had coronavirus, there were 1,434 women who've been admitted to hospital with confirmed COVID-19 during pregnancy. 1,399 included additional case data, and the pregnancy outcomes for those were similar to, very slightly higher than, but similar to the outcomes for the rest of the population as a proportion. So this is something we monitor very closely, and I have a concern to ensure that we get the very best information out and published, so that pregnant women and those who support them can take the very best possible decisions.
Thank you. You mentioned there about ongoing monitoring. What exactly is being done to monitor the effects of this disease? Because we obviously know it's very new, on pregnancy and on birth, and how is that being fed into clinical outcomes and commissioning?
Yes, well, the Dr. Jenny Harries, the Deputy Chief Medical Officer, is an expert in this area. The advice that she gives me is that in the first 2 trimesters there is no evidence of any particular impact of COVID that's different if you are pregnant. In the 3rd trimester, it is worth being cautious. There is not conclusive data, but there's a precautionary principle in order to, as there is with respect to many things in the 3rd trimester of pregnancy.
Thank you. In May this year, the committee took evidence from Jill Walton from the Royal College of Midwives, and at the time there were concerns about redeployment of key staff, including dual-skilled nurses, obstetricians and anaesthetists, and the effect that that's had on maternity safety. Have you taken action to address this, and are you satisfied that it's been dealt with?
Yes. One of the areas where if you call it the restart of the NHS has been essentially fully recovered is in maternity. It isn't a restart, of course, in maternity, because maternity services can't stop, whatever the depth of a pandemic, because there's a time limit, obviously. So this is an area where there's been an awful lot of work to make sure that the full quality of service is available and has been available as soon as possible. Clearly there's the need for infection prevention and control and the precautionary principle that I mentioned, but it's an area that the NHS has been doing a huge amount of work on.
Thank you. Sarah, final question. So Sarah mentioned the very important issue about fathers being allowed to attend scans and early labour.
Yes.
And I'm glad to hear that this is something that you're taking action on. You very kindly met the neonatal APPG to talk about the issue of parents being allowed to access to neonatal care on an unfettered basis. Can you just confirm again that there will be action taken on this, so that we know that mothers and fathers, often in very desperate situations, will be able to access the neonatal unit without any obstructions?
Yes, I think you're right, and Sarah earlier was absolutely right to raise this issue. It's incredibly important. It really matters to me. And this is something I've taken up with the NHS, and I'm very happy to write to the committee within a fortnight with an update on progress, and to make sure that we take take whatever action is needed to support, not only to support mothers and their chosen partner through this process, but also to support parents in neonatal intensive care, which is very important. And I heard loud and clear the message from the APPG, which is that parents aren't visitors. And throughout, we've had a different policy for visitors as to for parents of children who are ill, and especially those that are seriously ill. But we need to make sure that we get that guidance and advice right.
Thank you. Just a couple of quick follow-ups on maternity safety. In the House last week, you talked to me about HSIB, which obviously has a very important role in terms of the independent investigations they do into maternity incidents. And obviously you couldn't say what was in the Queen's speech.
Yeah.
But do you think it's possible we could see that HSIB bill in the next year?
I very much hope so.
Okay, thank you.
I think that's as far as I can go without breaking some convention.
I will pine my hopes on your hope. And the second thing is, I wrote to you last month about the concerns of baby loss charities, SANS, Baby Lifeline and the Lullaby Trust, about data protection law changes that could potentially mean that Embrace, who are, as you know, the people who collect the crucial data on maternity safety, might not find out about baby deaths if people have opted out. I just wondered if you've been able to look into that.
I am looking into it, and I'm very happy to write back again within a fortnight, if that's reasonable.
Thank you. And then last but not least, it wouldn't be a select committee if we didn't hear from Rosie, so I'm just going to hand over to Rosie, who's going to ask the last question this morning. Oh, Rosie, you need to unmute.
Oh, not again.
I want to hear the last question.
Thank you. Secretary of State, as COVID has encouraged rapid change in the way NHS services are provided, much of it good, but some of it with dreadful downsides. For example, face-to-face appointments with consultants are converted to telephone appointments. That works well quite often. But recently, a consultant from Clatterbridge NHS Trust told a patient that chemo wasn't working, and that it was terminal, nothing could be done. Nothing was done to ensure that patient was not on his own. Do you think it's appropriate that we deliver that kind of news over the telephone without putting in or ensuring there's some support there?
Well, I think it's a really, really important question. And I think the natural instinct of everybody would be to say that should be given face-to-face. I'm also aware of some of the evidence that came up through the use of video conferencing, that there is some evidence that patients prefer to hear bad news when they can be with their family at home, when it is well prepared for and organised. So I'm certainly not endorsing the individual example that you gave. And Clatterbridge is a very, very good trust, and the staff there are excellent. But what I would say is that we shouldn't automatically reject the use of telemedicine even in this scenario, because actually some people find that receiving bad news at home is better rather than in the unfamiliar circumstance of being in a hospital. But of course it should be done in a sensitive way where people have the support around them. And I think we need to learn from how this has been done with an open mind as to what works well, what must return to being done face to face, and where we can use the advances in technology. Even as a huge enthusiast for technology, I wouldn't have expected, frankly, any evidence that people prefer to hear bad news over a video conference than face-to-face. And when I saw that, I was surprised. But once you think about it, you can understand it if it's done sensitively. I hope that's a reasonable and nuanced answer.
No, absolutely, Secretary of State. The objection is not to the telephone call. That's keep it safe as well.
Yeah.
I think the difficulty here is the consultant knows the message they're going to deliver.
Yeah.
The patient doesn't know what they're getting.
Yeah.
So if you don't check that they're with their family, then this actually caused grave mental health. A great drop in the person's ability to deal with their illness.
Yeah.
It was awful.
Yeah, I think we're on exactly the same page. I can absolutely empathise.
Secretary of State, you've been very generous with your time. Thank you
Pleasure.
very much indeed.
Thank you very much.
Session closed. Order.
Portcullis House.
And social care, the Wilson Room, 8th of September 2020. Health and social care, the Wilson Room, 8th of September